Let's discuss screening. We'll discuss this session according to following learning objectives. First, we'll discuss the definition of screening. What screening is? What are various uses of screening? What is purpose of screening? We will also discuss the types of screening. Then there is difference between screening test and diagnostic test. We will discuss the difference between these two. And then we will discuss some examples of screening tests. Which tests are conducted? We will discuss lead time, and in the end, we will summarize the session. Let's start with the definition of screening. What is screening? Basically, screening is done in healthy individuals to detect or to diagnose a hidden disease. So, screening is a process in which we can say that's a process in which we diagnose a disease in apparently healthy individuals. And rapid tests are used to conduct screening tests. So there are three things. Disease, we want to identify the disease in individuals by means of tests. So disease should be hidden. Individual should be apparently healthy. They are not healthy, but they are apparently healthy. Test, rapid test, cause they are applied in population, they are applied on masses. Overall screening is a search. We are searching something, searching disease in individuals by means of tests. So we can define screening that screening is search of unrecognized disease or defect in apparently healthy individuals. You must remember the definition by means of rapidly applied tests, because these tests are applied on masses. So answer should be rapid. If these tests are rapid, there are chances of mistakes. There are chances of false negative and false positive by a screening test. That's why screening test is not final. That's why we have to go for diagnostic test. What are various uses of screening? Why screening is done? Number one, detect the disease. We want to detect the disease. We want to detect the disease at earlier stages. Because if disease is diagnosed at early stages, we will treat it and complications will be rare. But if the disease is diagnosed at later stages, there are chances of complication. We do screening to detect the disease at earlier stages. When we detect the disease, it will help in control, it will help in prevention, it will help in research, it will help in awareness and education. Idea is to educate our common people. So, basic uses of screening are detection of disease, control of disease, prevention of disease for research purposes and for education purposes. What is purpose of screening? Purpose of screening is to reduce the burden of disease, to stop epidemics. Because in non-communicable diseases, in chronic diseases, latent period is longer. Most of the time, disease is asymptomatic. Symptoms appear at later stages when complication develops. So, if we want to stop the complication, if we want to stop the epidemics of chronic diseases are slow epidemics, we will do screening. We want to protect our population. We need a healthy population. We want to protect the health of population. Basic aim is positive health, healthy community. That's why we do screening in high risk group or in vulnerable people who can develop disease like obese ones. We know that they can develop hypertension, they can develop diabetes. So we screen hypertension and diabetes in obese. Or we know low socioeconomic status female develop cervical cancer. There are greater chances of cervical cancer in low socioeconomic status female because their hygiene is poor. They might have multiple sexual partners. So we'll screen them. We'll screen cervical cancer, and if we diagnose it at earlier stages, we'll do the treatment and we will protect them, increase their lifespan, and prognosis will be increased. This is the purpose of screening. You can write protection. You can write prevention. You can write promotion. We will protect them from diseases. We will prevent the diseases, we'll prevent the spread of diseases, and we'll promote the health. What are various types of screening? There are so many types of screening which are applied in different communities in different diseases. We'll apply them according to our scenario, according to our budget. according to our resources, according to our manpower, according to our policy, and according to disease. So there are three main types. There is mass screening. Masses, that is done on masses, like that is done on whole community. Like in case of COVID, we can do mass screening. High screening, screening done on vulnerable population which is at risk, like obese. Multiphasic, we can do screening of two or three diseases in the same person, in the same population, but it needs money. Lot of budget is required. So let's discuss them one by one. What is mass screening? Applied on masses. It can have advantages, it can have disadvantages. Like in case of epidemics or in case of coronavirus, we will do mass screening. Why we'll do mass screening in coronavirus? We want to protect our community. Someone is asymptomatic as coronavirus, can spread coronavirus. It spreads regularly, it spreads through droplet infection. So we can do mass screening in case of coronavirus. We'll see the temperature. If someone is suffering from temperature, we will do diagnostic test on that person. So mass screening is performed in case of coronavirus. This it can have disadvantage. It can have advantage. What is advantage? Protection. Protection of community. Disadvantage. If we are doing screening on mass scale, it will create some fear. Plus, money is required. A lot of money is required to conduct that type of screening. Ideal type of screening is high risk screening. Will target high risk persons, those who can develop the disease, which are at high risk, those who are exposed to a certain risk factor, those whose family history is positive, they are exposed. Like someone is smoker and is smoking for 20 years, 30 years, we can screen lung cancer in smoker. Or someone is working in the industry, like industry which can cause pneumoconiosis, like in asbestos or silicosis. We will screen that person for lung cancer or for fibrotic lung diseases, or persons whose family history is positive for hypertension, for diabetes. We will screen them, or whose family history is positive for cancer, we will screen them. These are high risk. Remember, those who are exposed, those whose family history is positive, they are at high risk. We will screen them. So examples are cancers, like lung cancer. We will screen cancer in high risk or exposed group in smokers, hypertension, those who are obese, plus those whose family history is positive. We will screen them. This is high risk screening. Main advantage is it is cost effective. So you have to remember, cost effective. This is cost effective technique. We select high risk individuals, we'll screen them, and we can save the money, we can save the manpower. Cost. Screening process is time consuming. It is applied on communities. It takes time, it takes money. So we have to do targeted approach, a specific approach. That is high risk screening. Multiphasic screening, screening done in phases. Like in the same person, you are screening hypertension, plus you are screening diabetes, plus you are screening cancer. Budget is required, time is required to conduct that type of screening, and there may be errors. This type of screening, they done this screening in America, but now they are moving to high risk screening because we need policies which are cost effective. Health budget is limited. We have to create a health system in our resources. So these are the three types of screening: mass screening, high risk screening, and multiphasic screening. There is difference between screening test and diagnostic test. We all know that screening test is done on apparently healthy individuals. They are asymptomatic. There are no symptoms of disease in the screening population. But for diagnostic test, they have some clinical picture or they appear with symptoms. Person comes to you in the hospital, comes in the emergency of hospital with symptoms, like if we take the example of coronavirus. Someone is asymptomatic, we are doing screening. This is screening. But someone present with fever, flu, fever is high grade, he has productive cough. We do diagnostic tests. Or we are doing screening for hypertension in apparently healthy obese person. Or someone is presenting in the hospital with headache. This is the difference between them. Screening is done on larger group. It is done on masses. It is done on community. It's a community procedure. And diagnostic test is done on single subject, like one who has presented in the hospital with symptoms. Screening test is less accurate. Why? Because tests are rapid. They are rapidly applied tests. They are applied in masses. So there are chances of false positive and false negative. Diagnostic tests are usually accurate because they are done on one individual. Physicians, clinicians are taking time to diagnose. They are taking proper history. They are doing proper examination. They are doing proper investigations. So diagnostic tests are accurate. Screening tests are not conclusive. They give an idea. They give a way, and diagnostic tests are conclusive. They conclude that person is suffering from the disease or he is not suffering from the disease. And screening test is less expensive. Less money is required to conduct a screening test. Let's suppose in 10,000 rupees, we can do a screening test on 1,000 individuals or in 100 individuals. And diagnostic tests are expensive. One individual may take 20,000 rupees because different tests are performed. Like in case of coronavirus, screening test is temperature. It is less expensive. You can see temperature of thousands of person in 10,000 rupees. But for diagnosis of coronavirus, you need PCR. You need high resolution CT scan. These are expensive tests. And screening test is never the basis of treatment. Treatment is always done on the basis of diagnostic tests. These are the basic difference. Like screening is done on asymptomatic, it is less accurate, it is less expensive. It is done on larger groups, it is done on communities. But diagnostic test, it is accurate, it is conclusive, but it is expensive. So there are certain advantages of screening test and certain disadvantages of screening test. Major advantage is that it is cost effective. It is applied on community. Major disadvantage is that it can generate false negative and false positive tests. Major advantage of diagnostic test is that it is accurate, it is conclusive, but major disadvantage is that it takes money, it is expensive. It is easy to perform screening test of coronavirus in a community of 10,000, 1 lakh, but it is difficult to do diagnostic test on 100 or 1,000 persons because diagnosis take time, it takes money. So these are the basic differences. It can be asked in university. It's a common university question. So what is difference between screening test and diagnostic test? So you must remember this. These are the examples of various screening tests. Like in pregnancy, you see weight, TBC, complete blood count. Why weight and complete blood count? Because in pregnancy, weight increases and hemoglobin may decrease in pregnancy. Blood sugar. Blood sugar may increase during pregnancy and can cause gestational diabetes. So we can do these tests during pregnancy: weight, complete blood count, and blood sugar. For infants, growth charts. Why growth charts? We want to see their growth. Metabolic screening for metabolic syndromes in children. Hearing test. Hearing defects are common nowadays in Pakistan. Most of the children are suffering from hearing problems. So we'll do this screening test. Elderly people suffer from cancers, cause cancer is disease of old age. They may suffer from depression. So we'll screen depression. Vitamin deficiencies due to imbalanced diet. We'll screen vitamin deficiency in elderly population. Adults. Lipid profile or cholesterol is a growing problem nowadays. Most of the people are taking fast food, they are not taking balanced diet, so their lipid profile is deranged. So we'll screen them for lipid profile, for cholesterol. Blood pressure is problem in middle-aged people nowadays. We'll trace the blood pressure, we'll measure the blood pressure, we'll monitor the blood pressure. BMI, there are chances to develop obesity in this age. So we will continuously monitor BMI to prevent obesity. All of these tests are done to prevent certain diseases. All of these tests can be done at different ages because different ages have different problems. Problems change with growing age. In infants, there are growth problems, metabolic problems, hearing problems. While when they become adults, there are lipid problems, there are cholesterol problems, there are blood pressure problems. They tend to become obese. And they become elders, they can develop cancers, they can have depression, they can have vitamin deficiency like vitamin D deficiency, vitamin E deficiency. And pregnant women have different problems. Their weight can increase or decrease. Their hemoglobin level can decrease, plus their blood sugars. Even blood pressure can exceed during pregnancy. So we have to screen for all these problems. First, we should know what are the problems of different age groups. Then we will screen. Then we will perform various screening tests in these age groups. A person apparently healthy, a middle-aged person will be apparently healthy, but if we screen him or her for cholesterol level, his cholesterol level can be increased. We know that high cholesterol level can lead to heart problem. So we are preventing heart problem by controlling cholesterol. He may have asymptomatic hypertension, and blood pressure can lead to stroke, which is a common complication. While controlling blood pressure, we are controlling stroke. BMI is increasing. It may lead to hypertension, diabetes. So we are controlling diseases by screening. Screening tests are useful for control and prevention, for protection of our community. Now we'll discuss lead time. What is concept of lead time? Lead time spares our time. Lead time is a benefit. Lead time is an advantage. But this advantage is gained by screening. We do screening and diagnose the disease at earlier stages. Then we can control it. Like if we diagnose a certain cancer at stage 1, it will be easier for us to treat, to control, to rehabilitate. All the levels of prevention can be applied. But if we diagnose the cancer at stage 4, treatment is tough, prognosis is poor, cancer may metastasize, person may die. So this is the importance of lead time, that we have to diagnose disease before time, before the onset of symptoms. Lead time is the advantage gained by screening. You must remember this. Is a period between diagnosis by early detection and diagnosis by other means. What is meant by this? Diagnosis by early detection means by screening. By other means that when signs and symptoms appear and he report to hospital. The benefit of program must be seen in terms of outcome. Yes. Outcome is prognosis. If prognosis is good, we know the treatment of the disease, we'll do screening. An outcome of disease. A is outcome and B is outcome to be expected. One is natural outcome of the disease, one is expected outcome of the disease, and BA is the benefit of the program. We'll see the diagram. A, usual outcome of the disease. When disease process or unfolding of disease continues from start, from risk to outcome, and there are no interventions. This is natural history of disease. We have to do certain interventions to prevent the disease. We need to prevent the disease to protect our population. So there are various stages in disease process. It doesn't process in night time. It takes time. Like disease onset detection. This is a risk factor. There is first possible point. There is final critical diagnosis, the point where disease is diagnosed by screening. And there is usual time when it is usually diagnosed, when symptoms become apparent, like a person is suffering from hypertension. There is first possible point, there is final critical point, there is usual time when he or she may develop stroke, he or she may develop malignant hypertension, he or she may develop ischemic heart disease due to hypertension. We have to diagnose before this stage to protect our population. So this is the lead time. We'll diagnose the disease between these three parameters: first point, final point, and usual time of diagnosis. It is diagnosed before usual time of diagnosis. This is benefit. B is the benefit that is gained by screening, as I have mentioned. This is the benefit. We conduct a screening program. Why we conduct a screening program? We are conducting a screening program to benefit our community, to improve the health of our community, to diagnose a hidden disease in our community. So that's why we want a cost-effective program. We want to save our cost. We want to improve our health system. We want to improve the health status of our community. So we have to diagnose the disease before the usual time of diagnosis, before the appearance of normal signs and symptoms. That is the concept of lead time. Usual time. We want to get an advantage. Program must have an advantage. Otherwise, this is useless. This is lead time. Now, we'll summarize the session. What we have discussed. We have discussed screening. We have discussed its definition, its types, uses. Then we have discussed lead time. We must know what is screening. Screening is a search. Search of what? Search of a disease, search of hidden disease or unrecognized disease or defect in apparently healthy individuals. And we have to apply rapid tests. Screening test may have disadvantage. It may have false positive and false negative results, but it has certain advantages. We do screening for chronic diseases, for those diseases who have greater latent time, who gives us time to diagnose. And then we discuss the uses, control, prevention, research, education of community. Then we discuss that there are three types of screening. These types are mass, high risk, and multiphasic. Mass screening is done on masses. High risk screening is done on high risk individuals, and multiphasic is done. Two or three screening programs are done simultaneously in the same individual. We also discussed various screening tests. Remember, diseases are different. Our diseases are specific for specific age groups. For infants, there are different diseases. For adults, disease is different. For older ones, disease is different. For pregnant female, disease is different. So we have to screen, we have to target pregnant female, and we have to screen high hemoglobin levels or anemia in pregnant female. We have to screen hypertension and diabetes in pregnant female. Why we want to screen this? Because their burden, studies have shown that burden of gestational hypertension and burden of gestational diabetes is increasing with time. And in our population, in Pakistani population, there is greater tendency to become anemic during pregnancy. Female are anemic during pregnancy, so we want to screen anemia, cause maternal anemia can lead to fetal defects, child abnormalities. So we will screen it, then we will diagnose it, and then we treat it. Basically, it's a chain. First, you find someone who is at risk, then you apply something on it, then you will apply diagnostic test, and most important, you have to treat the problem if you diagnose the problem. Elderly population have cancer, incidence of cancers is increasing in Pakistan. You have to target those female who can suffer from cervical cancer. You have to target those males who can suffer from lung cancers. Like same way in infants, they can suffer from metabolic disorders, hearing disorders. So this is the process. These are the various screening tests, like we'll do CBC, red blood count, we'll do R factor, we'll do hemoglobin level, we'll do blood sugar level, and then we discuss lead time. Screening must have some benefit. We are doing screening for to gain some advantage. Lead time is basically the advantage, the benefit that is gained by screening. There are various stages in the development of disease. Like in natural history, we discussed that it's an unfolding process from risk factor to outcome. But between them, there are stages. From risk factor to outcome, there are phases. There is pre-pathogenesis phase, there is pathogenesis phase, there is early pathogenesis phase, there is late pathogenesis phase. Then there is outcome. Outcome depends on the severity of these phases. We do interventions. We will intervene during these phases. Lead time is basically the intervention before the outcome and final critical stage to gain some advantage to diagnose the disease in time. We want to diagnose the disease in time because we want to treat the disease. If we detect the disease at earlier stages, treatment is easy. There is prognosis. Our prognosis will be greater. But if we diagnose the disease at later stages, prognosis is poor. That's why screening is done. Screening is done to protect our population, to prevent the disease and to reduce the burden of disease, to reduce the mortality and morbidity of the disease. That's all.